Hi, everybody. I'm Laura De Girolamo. I'm working at the Galeazzi Orthopedic Institute in Milan, where I'm the director of the Orthopedic Biotechnology Laboratory and of the Regenerative Galeazzi Institute. First of all, let me thank the AGA for this nice invitation to participate to this interesting congress, and in particular, thanks to Philip Niemeyer to involve me. So I've been asked by Philip to talk about the rationale of cell-based therapy in musculoskeletal regenerative medicine. Actually, of course, in a few minutes, it's not easy because, as you can see already, cell-based regenerative medicine is a very complex field because we have many different products, we have different cell tissue donors or sources, we have different approaches. So, of course, in this short communication, I will just give you some key information regarding the use of stem cells in regenerative medicine. If we go to straight to the type of cells we can use, we can mainly do a big differentiation between differentiated of mature cells and undifferentiated cells. A nice example of differentiated cells in the musculoskeletal setting is the use of autologous chondrocyte implantation, where chondrocytes are isolated from biopsy of healthy cartilage in a GMP facility, expanded till they reach millions of cells, and then sent back to the surgeon for the implantation in the focal defect, where usually a graft is sutured over the cartilage lesion. Instead, if we think about undifferentiated cells, surely mesenchymal stem cells are the most used and the most useful cells for regenerative medicine application. Actually, MSCs are cornerstone of regenerative medicine, not only in musculoskeletal tissues, but also for all the other applications. And some scientists refer to MSCs like the 21st century penicillin, just to let you understand how crucial, how important are these cells for us. So how we can identify these cells? Because MSCs are actually in every organ or tissue of our body. Actually, MSCs are live together with other cell populations. So the first scientists who identified the MSCs had to find out the way to isolate or identify these cells from the other cell population. So we can talk about MSCs if these cells are able to adhere to plastic, to proliferate, to express a specific phenotype, which is in particular related to the expression of specific cell surface marker, like CD73, 90, and 105, but many others. And also, if these cells are able to differentiate at least into 3 cell lineages, and in particular, adipocytes, osteoblasts, and chondrocytes. The multipotency of MSCs has been for many years the crucial therapeutic potential of these cells. Indeed, these MSCs through the mesogenic process and under appropriate stimuli can differentiate, so can acquire the phenotype of mature cells of bone, cartilage, muscle, tendon, or ligament. And this has been the key of the therapeutic potential of these cells. MSCs have been found first in bone marrow, then in many other tissues, and now today we isolate MSCs from adipose tissue, tendons, and other fluid. But as you can see from the table, you can actually find MSCs in almost all our tissues and organs. And the presence of MSCs in all these tissues and organs is related to their origin. So I have a quick question for you. What structure do most organ and tissue have in common? The simple answer is blood vessels. And indeed, MSCs are present in all our tissues because they have a perivascular origin and that they are a subset of pericytes. Pericytes are cells which are wrapped around capillaries on blood vessels, and they express the marker CD146. So not only the pericytes are MSCs, but all the MSCs are pericytes. So this means that every single organ and tissue who has a vascular network actually possess MSCs. And what these MSCs do? So when an injury or an inflammation occurs naturally in our body, in our tissue, the MSCs, the pericyte, detach from the blood vessels and progressively acquire an activated MSCs phenotype. In this phase, the cells start to release a plethora of different molecules with different effects, with different potential, anti-scarring, anti-apoptotic, pro-angiogenic, pro-mitogenic. and actually they participate to the healing process of the tissue through the interaction with resident cells. So the release of these molecules is the way MSCs get in contact with the resident cells, terminating inflammation and creating a more receptive microenvironment for the action of the reparative stem cells. So for example, what happens when we inject MSCs, a solution of MSC in an osteoarthritic knee? Actually, MSCs start to release, according to the microenvironment they are in, because they sense the microenvironment, anti-catabolic molecules, anabolic molecules, and even more important, anti-inflammatory molecules, which of course bring a relief for the patient. So we can see cells as drugs because they release molecules, bioactive molecules, and they do not release a single molecular agents, but a cocktail of drugs. And so the cocktail of drugs is received by the resident cells, by the receptor of the resident cells, which start the process of tissue repair or tissue regeneration. So because of this, more recently, the scientists who are working for years in the field proposed to change the acronym MSCs into medicinal signaling cells. So still MSCs, not anymore mesenchymal stem cells, but medicinal signaling cells, just to underline the importance of signaling of these cells. So can we talk about cells with a disorder, multi-personality or bipolar disorders? Yes, I think we can somehow, because still MSCs are able to differentiate, integrate into the target tissue and provide a cell replacement. So we are still, this is still true. But now we know very well that there are many other ways the cells get in contact with the resident cells, with the target cells, through paracrine activity, cell-to-cell contact, but also mitochondrial transfer and extracellular vesicle release. Also, the terminology is very important, especially when you talk with your patient, but it's also very important when we talk with our colleagues, because as I presented at the beginning, if we want an MSCs population, an homogeneous cell population, we need to pass through the lab, because we have to expand the cells, we have to characterize the cells. So this is MSCs. But more frequently, very likely, you are using a BMAC, SVF, microfat. And in this way, you are not using MSCs, but you are using the perivascular cells in their stem cell niche. And of course, this is a more cost-effective technique, but surely less standardized than the MSCs. So you have two ways mainly to use MSCs. In an implantation strategy setting where you exploit the ability of cells to specific differentiate into tissue cells, which are aimed to cell replacement and eventually lead to tissue restoration and healing. And on the other side, you can also use cell therapy, exploiting the paracrine regulation of tissue repair by the release of soluble bioactive factors, which eventually lead to immunomodulation and again, tissue restoration and healing. So my take-home message is that MSCs can play a dual role according to the indication and the administration route. These cells are very versatile, which make them potentially suitable for multiple indications, alone, of course, but also in combination with surgery, other biologics, and biophysical stimuli. And please respect the terminology. It's very important that we distinguish MSCs from SVF, BMAC, or other point-of-care products. Again, thank you very much for this opportunity, and please check out the recently launched ESCA Orthobiologic Initiative on the ESCA website. Stay tuned for more information if you're interested in this very interesting field. Thank you very much.